Good. All right. Thank you, Dr. Canner. I would like to introduce our second presenter now, sponsored by Advent Health and SK Life Sciences. She is also the chair of today's event. Oh, I just lost all my notes. Got to introduce you well there, Dr. Kettani. She will be discussing her top memory and behavioral commodities. Dr. Kettani is a board-certified and fellowship-trained neurologist specializing in epilepsy. She is passionate about educating her patients and their family members on epilepsy and seizure treatment options. Dr. Kettani provides comprehensive care and behavioral conditions associated with seizures, including education on how to recognize and initiate aid to the ongoing management and treatment of the disease. She's currently in Tampa practicing at Advent Health Hospital and is also an Epilepsy Florida board member. Welcome, Dr. Kettani.
Thank you for the kind introduction. I'm happy to be here again. This is very exciting. Unfortunately, we could not host this event like last year physically, but we have the virtual options and the option to educate our patients, and also have a lot of people join us from all over the world. We have some colleagues from Morocco who joined us in this interesting meeting. So that's very exciting, and welcome to everyone. I always try to, in this event, to keep it simple, and the presentation is regarding how epilepsy usually affects your life and your family's life. This year, I choose to speak about epilepsy and psychiatric comorbidities. Next. What is epilepsy? Epilepsy is derived from Greek epilepsia, which means to take hold of or seize. Unfortunately, people with epilepsy live with fear, suspicion, misunderstanding, and they are subject to enormous social stigma. They used to be treated as outcasts and punished, and unfortunately, they continue to be subject to social stigma. However, some of them became famous, and Julius Caesar, for example, Popius, and many others. In 1873, early on, a British neurologist suggested that seizure was an abnormal electrical discharge in the brain, and the manifestation will depend on where is the seat of the discharge. And in 1920, it was another intelligent psychiatrist who discovered EEG, and after that, we were able to read brainwave activity. Next. What is a seizure? A seizure is a transient occurrence of signs and symptoms due to abnormal excessive synchronous neuronal activity in the brain. It sounds like it's a different language, but exactly what it means is a bunch of neurons in the brain get angry and provoke a chaos answer and a chaos electrical activity. And depend where is that activity originating from, the body is going to manifest clinical manifestation. A single seizure can occur in any individual and is not considered to be epilepsy. And epilepsy is the neurological condition that is characterized by tendency of recurrent seizures, and mainly unprovoked recurrent seizures, means seizures that are not secondary to drugs or some abnormal electrical imbalance in the, metabolic imbalance in the body. Next. Electrogenesis is the process by which a previously normal brain is functionally altered and biased toward the generation of abnormal electrical activity, which leads to chronic seizures. And the concept of mechanism of epilepsy refers to any biological features of the brain that drive or support the recurrent and provoked seizures, which include molecular, anatomical, at cellular level alteration, or dysregulation of an ion channel or neurotransmitters receptors. Yes. So what are the psychiatric comorbidities with epilepsy? Epilepsy, as we know, is a chronic disease. It is associated with risk of a variety of psychiatric and medical comorbidity that can, unfortunately, affect the quality of life as well as life expectancy. The comorbidities can arise due to common underlying predispositions, direct effects of seizures, underlying epilepsy etiology, and adverse effect to the medication we give to treat seizures and other therapies. Depression and anxiety are the most common type of psychiatric manifestation that are associated with seizures. Next. Risk factors. Clinical factors include the age of onset of the seizure, how long the individual has been suffering from seizure, the type of seizure, the frequency, and again, where it's originating from, and that's very important. The psychosocial factors include the chronicity, the low socioeconomic status, the low education, the stigma that epilepsy carry, the legal limitation, learned helplessness and overprojection by family, and a lot of other things. Biological factors include the damage to the brain area of psychiatric function or secondary electrogenesis or, again, anti-epileptic drug side effects. Next. In psychiatric disorders that are associated to epilepsy, there's two types. Some are attributed to the brain disorder causing epilepsy, such learning disability, specific epileptic syndrome, cognitive behavior manifestation, or other acquired cause of epilepsy. Then we have another type that is strictly related to the time of the seizure, which can happen before the seizure, at the time of the seizure, or after the seizure, means pre-ictal, ictal, or post-ictal. Next. Ictal disorders. During the seizure, the individual may or may not have cloudiness of consciousness, hallucinations, forced thinking, thought that can mimic psychosis, ictal anxiety, and sometimes they have panic attacks, which could be either a panic attack or manifestation of seizure itself, because the seizure is originating from an area of the brain where the panic attack is coming from. Epileptic automatism also, such as repetitive movements. And it's important to remember that seizures are not always the major convulsions or the generalized tonic-clonic seizures. They could be other symptoms that we may not be aware of, such as lip smacking, hand rubbing, walking in circle, meaningless phrases, or even undressing. And I had a patient, unfortunately, that has been admitted multiple times to the psych ward because she would just take off her clothes in a supermarket, but unfortunately she had seizures, and it took a long time before she was diagnosed with seizures. So I, as an epileptologist, anything that looks different, strange, I don't always blame it just psychiatric condition. It could be epilepsy, or it could be a combination of both. After the seizure, what can happen? Sometimes patients go into delirium and they could become responsive after a short period of time, or take longer, especially in elderly or patient with learning difficulties. The one that is scary is post-ictal psychosis. It is not very common, but it's there. And it's usually in patients who have had seizure for a long time, poorly controlled, and more than 10 years. The risk factor for post-ictal psychosis is mainly when they have at least two foci of where the seizures is coming from, or they have also lesions in the limbic area of the brain, which generates emotions for any individual. And if they had encephalitis, which is infection of the brain tissue, and usually encephalitis, certain virus attack that specific area. And the onset of it could be sudden, could be traumatic, they could have been agitated, and they could act upon and be violent sometimes. Next. The duration of post-ictal psychosis is from 16 hours to 18 days. It could be shorter, it could be a little bit longer. And sometimes it will warrant the patient to be admitted to a hospital and get treatment for it, but usually they don't because it's self-limited. Next. Now, intra-ictal disorder, which means in between seizures. They could be depression or anxiety, and these are the two that are more common in patients with epilepsy. Next. Next. There are some type of seizures based on where they originated from. They don't have the typical behavior of what we know as a generalized seizure, as a generalized convulsion, or what is everybody's familiar from. If a seizure foci means the bed area in the brain that generates seizures is in the frontal lobe, which represents 20 to 30% of localized epilepsy, these individual will have abrupt and sometimes some very uncommon at nighttime behavior that can mimic some psychiatric or behavioral manifestations, and they are most of the time mistaken for psychiatric behavior, but these ones are seizures. Next. Then if the seizure foci is in the parietal lobe, then the patient may experience tingling, numbness, or crawling sensations, and they could be mistaken again for neuropathy or other peripheral neurological problems. Next. Then we have the occipital epilepsy, and it's mainly in children, but when it occurs in adults, it can mimic migraines because of the visual hallucinations that are typical of occipital epilepsy. Next. Next. The most common psychiatric problem that we encounter with epilepsy is psychotic disorder. They can, what is a psychotic disorder? Is an abnormal thinking or perception, and psychotic individual most of the time lose relation with reality. There's two types. Positive type, which means they have manifestations, hallucination, delusion, disorganized behavior, and the negative one, where they could become catatonic or decrease muscle tone. And it's been noted that patients with temporal lobe epilepsy and psychosis have significantly small brain volume compared to patients who have only temporal lobe epilepsy without psychosis. Next. How do we manage psychosis and seizures? Again, because it's self-limited, usually we don't treat the patients, but if it's extends to a certain period of time or a patient become violent, then we may use certain medication. Usually, if it's intra-ictal, it means in between seizure, they last usually a bit longer, and a patient could benefit from medication. But again, we have to use medication with caution because some of them can decrease the seizure threshold. Next. Then bipolar also is another condition that is associated with epilepsy, and it is a misconception that bipolar is when patients get upset or just get angry, but it's a chronic psychiatric disease which patients have mood swings, and they could go from becoming sometimes psychotic or very maniac or becoming very depressed. So it can be confusing sometimes. Next. Depression and anxiety are the main ones. Depression is feeling of sadness, loneliness, despair, or low self-esteem, and is the most common psychiatric comorbidity seen in patients, and mainly in poorly controlled seizures. And why I insist on poorly controlled seizures? Because most of these psychiatric conditions occur less if patient is treated properly and they have less seizures. There's hypothesis about depression and epilepsy, that depression is a reaction to the epilepsy, or the depression is part of the epilepsy. Next. The factors that are associated with it to reinforce that theory is that there is decrease in some neurotransmitter, serotonergic and adrenergic, and have been identified in depression. And sometimes the same neurotransmitter can be decreased in seizures or facility to exacerbate seizures. So that's why when seizures are treated properly and depressive problems are treated properly, we see an improvement in quality of life by decreased number of seizures. Next. Anxiety is also very common, and it's again more common in patients with uncontrolled epilepsy. And the risk factors, we discussed them earlier, is mainly the social ones, because they're subject to unemployment, activity restrictions, impaired social support, and so forth. Next. Some of the medication could have a positive impact in mood and can treat seizures and epilepsy at the same time without having the individual take 2 medication for one. But there are some other medication also that can worsen the mood. And the one that is mainly well known is Keppra, that could induce sometimes a psychotic event, but it's very rare. And it's also a great medication for certain patients. Next. Suicide risk is a big concern, and it can be part of an intra-ictal mood disorder or post-ictal symptomatology. It is again elevated, and the risk is higher in patients who are poorly controlled, and it's more frequent in individuals who have many comorbid psychiatric conditions associated with their epilepsy. Some anti-seizure medication have been also implicated in increased risk of suicidality, and mainly those ones that affect the mood. And the additional risk factors include male gender, temporal lobe epilepsy, and high seizure frequency. Next. ADHD is also common, and there's a misconception sometimes that the medication for ADHD can induce seizures. Yes, all anti-psych medication have to be used with caution. And there are some also anti-epileptic medication that can cause some side effect that can mimic ADHD. So therefore, the diagnosis has to be made carefully. Next. There are also some personality disorders that have been noticed with seizures, such as viscosity, hyposexuality, religiosity, hypergraphia, and aggression. Next. Then we have the other topic is the non-epileptic seizures. What are non-epileptic seizures? Sometimes patients have been through difficult life experiences, and they have these out-body experience where they have a convulsion, but it's not necessarily originating from an epileptic foci, means an area of the brain that is suffering. It's mainly from the mind or a serious emotional pain. And sometimes they could be conscious, and they could involve some kind of gain. Next. Next. So how do we manage epilepsy and in general? To manage epilepsy, we have to take in consideration the psychosocial dimension of the disorder, which means a medical and psychiatric comorbidity, because patients suffer from loss of independence, unemployment, and decreased leisure time, decreased activity. And we have to take in consideration also the other medical and psychiatric comorbid issues. They have to choose properly the medication they will benefit from without suffering from side effects, and giving them a better quality of life by controlling their seizures properly. Next. For the psychiatric condition that occur in patients with epilepsy, again, we have to choose the medication carefully because we don't want to worsen any comorbid condition. And some medication have double effect in treating psychiatric condition and epilepsy at the same time. Or if we need to add certain medication, we have to be careful if they decrease the seizure threshold or if they don't. Next. Also, as Dr. Kenner talked about earlier, the vagal nerve stimulator can have antidepressant properties. So in patients with epilepsy and depression, it could be a useful neuromodulator options to consider. Some medication like carbamazepine, valproic acid, lamotrigine, oxcarbazepine, they are used in psychiatry because they have mood stabilizing properties, and gabapentin and pregabalin could be used as anxiolytic as well because of their anxiolytic properties. Next. Next. In conclusion, psychiatric comorbidity in patients with epilepsy are frequent. Early recognition and management of psychiatric disorders in patients with epilepsy is extremely important. Our main goal is to improve the quality of life and help with better seizure control. Choosing the right anti-epileptic drug based on the side effect and their impact on pre-existing psychiatric symptoms can help avoid worsening of patients' symptoms and help in treatment compliance. Can we go back? The other one. Yes, resources. So there are a lot of resources out there. I highly recommend to not just Google epilepsy and rather go to trusted websites that have very focused educational material and very legit and reviewed by experts as well, such American Epilepsy Society. They have for a whole section for patients and families, Center for Disease Control, Prevention, Epilepsy, Epilepsy Florida, epilepsy.com, Epilepsy Foundation. And we could go to before that. Okay. So our programs are intended to improve knowledge about and attitude toward epilepsy. We aim to fight the stigma associated with epilepsy with the continuous educational efforts we provide. And my message to everyone is that there's nothing more debilitating about a disability than the way people treat you over it, and no one is in control of your happiness but you. Therefore, you have the power to change anything about yourself or your life that you want to change. So let's change epilepsy. Thank you.
Thank you, Dr. Kettani, and thank you for those words, very inspiring. We do have some questions for you. One of the first ones is related to memory. So if a patient has temporal lobe epilepsy and they have memory impairment, should they have the surgery? Would the memory return? Would they regain the memory loss?
Okay, so when the seizure originates from the temporal lobe, unfortunately is affecting that area. And the temporal lobe are the memory center because of all the emotion that goes in, and when you retain an information, it goes circle around before it gets stored. So that's an important place where the information gets processed and decide to be stored or not stored. When there is a disruption of the connectivity in the neurons, or this hyperexcitability we talked about, and if that person has been having multiple seizures, they were not treated properly, and they were not completely controlled, there is some damage that's already been done. When we do surgery is to prevent from a progression. Sometimes it's noted that it improves because these patients have been having multiple seizures, sometimes that are not always convulsive, and there's interruption of a focus which makes them think they cannot retain information, but they probably missed the information. So when they have surgery and their seizure improve, or they're completely cured, they don't have seizures anymore, or they are on less medication, then yes, the memory can improve.
Perfect. Thank you. We have another question. Well, actually a statement from one of our attendees. She said that her seizures were caused by trauma and she has panic attacks. She has simple partial seizures, 20 to 25 simple partials, and complex partials a month. Her neurologist found a medication that stops the panic attacks and simple partial seizures, but he has never been able to help the complex partial seizures. Her seizures started when she was 18 years old. She cannot stand diazepam because of it causes terrible concentration problems in her. She has been on 3 other medications that do not help at all. What are your suggestions for our attendee?
Well, the first and foremost is to make a formal diagnosis. These are epileptic seizures, by doing a video EEG and determining that the focus, and also having these events recorded and interpreted along with reading brainwave activity to confirm these are epileptic. So if they are epileptic, there are some epileptic seizures that manifest themselves as panic attack, because again, the focus, the seat of the discharge is in the area that caused the behavior manifestation. Or it could be because they had a prior trauma that is not necessarily a head trauma, an emotional trauma, and there is some form of dissociative disorders or other condition associated with it. When we do the video EEG, we're able to identify, is that event that is described as the typical event is epileptic or non-epileptic? And for each one of those, there's a different treatment. If it's epileptic, then we have to use anti-epileptic medication. And we'll have to use with caution the anti-epileptic medication, because we should not use the ones that affect the mood, because there's a mood component in this type of seizure. And if they're non-epileptic, then we have to refer for therapy, and we may consider antidepressant or anxiolytic medication. So that's the first step.
Thank you, Dr. Kettani. We have one more comment from the attendees, and that is, I feel an aura sometimes. It presents itself as an out-of-body feeling. It's almost like I'm not fully checked in or fully there. I work as a server, and it happens at work sometimes, but I'm able to carry with my work and no one notices. It doesn't last long, usually anywhere from 10 to 50 seconds. It doesn't lead to a seizure though. It just happens and then leaves. Is this normal?
No, it's not normal. It means that the seizures are not fully controlled. When we say an aura is kind of a form of a focal seizure. It used to be called simple seizures, but the problem with that word simple or complex, there's nothing simple or complex about it. It's the type of seizure, type of manifestation it has, type of complication it comes with it, type of medication that you will need. So for this individual, I highly encourage him to report the symptoms to physician, to probably titrate up the medication to a tolerated dose, or maybe add another medication or consider other options. But definitely experiencing aura, even if others are noticing them, is a form of seizures. And when you have seizures, it's this area of the brain that is bad. And it's bad and it stays on its own. It influences the other area and try to recruit. So we don't want that recruitment. We have to stop that. Once it's recruit more, then we have a larger area, and that's what we call in epilepsy consent.
Thank you for that answer. One more question. Lately, my seizures seem to be caused after I work out, and it leads to anxiety and depression because I feel helpless that I cannot do my daily activities. And as far as medications, they affect mood. Is there anything you may suggest?
Definitely to revise the medication, to use ones that doesn't affect the mood. I mean, we are very fortunate in this era to have this many options to treat seizures, to have a better understanding about seizures. So there is a lot of hope. I recommend highly to anyone who suffers from seizure to be seen by a specialist, because even if you are a neurologist, you may not know every area in neurology. Neurology is very complex. You may know a little bit of everything, but there's so many subspecialties, and the people who suffer from epilepsy need to be seen by epileptologists, because if they are treated properly at the beginning of their seizures decrease, they get the proper care, the quality of life is better, and the seizure doesn't get worse. It doesn't transform to a more chronic, complicated condition. So what I suggest is maybe the medication they're on has to be changed, to maybe discuss if this is anxiety or it's really seizures, and find out really what is the cause to get to the bottom of it.
Thank you, Dr. Kettani. There's so many questions for you. And I have promised just a couple of more. One question is, what type of brain waves are most affected by seizures?
Okay.
And another one, would like you to speak a little bit more regarding your comments regarding the auras or the simple
Yes.
partial seizure.
Okay, so I'll answer first the aura, then I'll go to the brainwave. So the aura, it's a manifestation, it's an experience, it's a symptom, right? It's not that individual experience it doesn't have control. So when you don't have control over something, it's kind of unconscious, means there is an area of your brain that is misbehaving. So that area of the brain that is misbehaving doesn't have enough power to recruit other area to get to a full seizure. Means a full convulsion that everyone can see, and it's not just a smell or taste or feeling or panic or sensation. There's no loss of consciousness because it stays in that little area. Okay. So sometimes at the beginning of the seizures, patients they say, oh, I just had first time seizure, but maybe it's been there for a long time. It's not first time, because if we really get appropriate history, we could find some different type of smell, different type of taste, this déjà vu, some anxieties. We can always go back and find something, and we will most of the time, which means that there was an area of the brain, again, tiny one, that was misbehaving. They were causing just a tiny bit of symptoms. But then over time, this area recruited and became a bigger area. And then once there is a bigger area, as of the definition that I said earlier, and sounds complicated, when it's a tiny area, you don't see a physical motor manifestation. But when it's a bigger area, then it takes over, and then your body will have that experience. So for the aura, again, is a tiny area that is most likely in the temporal lobe and the area of the memory, and it caused that kind of symptom, and it didn't progress yet to a big one. As far as the brainwave, what is a brainwave? So brain are made of neurons. They communicate with each other with electrical activity. And there was a machine that was discovered in 1920 that was able to record that, which is very impressive. So basically, they use electrodes in the brain, not in the brain, in the surface. And those electrodes record the electrical activity. But because it's so small, it has to be amplified, we're able to read it. You go to a machine, it gets bigger, and we're able to read them. So brain communicate with electrical activity. Then when we want to look at the electrical activity is the brain waves. There is a pattern, which is normal patterns for brainwave activity, some benign finding, and some findings that are suggestive when a individual have them. They're suggestive that that person may have seizures, or that person really have seizures, especially if they have events recorded with this abnormal activity. So brainwave is the display after being amplified of this electrical activity, this communication between the neurons and the brain.
Thank you so much, Dr. Kettani.
My pleasure.
Awesome, great.